Good morning, everyone. So this morning I'd like to present on some of the work that we've been doing over the last 5 years with the Wa Eczema Project, paediatric eczema, sharing the care. And this is really to share with you some of the key aspects from some of the work that we've been involved with. I won't be going into lots of detailed information about all the aspects because otherwise we'd be here till lunchtime. So if there's any particular aspect that you're interested in, whether it's the pharmacy model or to do with the child health nurses or the GPs, you're very welcome to contact me at any time, and I'm very happy to share the detailed information with you. And before I continue, I just want to acknowledge these amazing people, because this has not just been about establishing a nurse practitioner-led eczema model of care. It's really been collaboration, consultation with a huge number of people, and of course including our consumers and their lovely families. So these are some of the things that I'm going to share with you this morning over the next half hour. But really, why eczema and why eczema in children? So we know that it's really common. The incidence of allergic disease is rising, and especially food allergy, for which eczema might be a predisposing factor. So eczema is common. In Western Australia, we've just got one paediatric tertiary hospital. And so we get lots of referrals for children with eczema, and a lot of these referrals are actually for mild to moderate eczema. So most of these referrals, in fact at least half of our referrals, can be well managed in the community with the right support and the right resources. Before we started this work about 5 years ago, we had an over 3-year wait list for most of our children with eczema. So they just they were referred and sat on our wait list, our hospital wait list, for over 3 years. We know that eczema significantly affects not only the child, the family, it can affect school, mental health, growth and development, etc. So it's really important to optimise the eczema in these children, so we needed to do something different. So this project, the Wa Eczema Project, was funded by the Perth Children's Hospital, the PCH Foundation, and the Stan Pron Charitable Foundation. And absolutely without their support, this work would not have been able to be possible. So we're very, very grateful. We received a grant thanks to our medical colleagues, Dr. Roland Brand, dermatologist, and Associate Professor Richard Lowe, and that $800,000 was for over 3 years, commencing in late 2018. But due to COVID, we were able to extend this because some of especially the face-to-face consultations, etc., was delayed, and we weren't able to do as many face-to-face sort of education sessions, if you like, with healthcare professionals, so we did do a lot of online. We were tasked with developing a new model of care to better link the child and their family with community and specialist care providers, as highlighted in this figure from National Allergy Council. And it was really nice as we went along, as we progressed through the model, there were important aspects to add to this shared care model. And so this is the final model, if you like, to date. And I'm now just going to talk about some of the key performance indicators that we addressed as part of this work. So wait time reduction, so our over 3-year wait list was a really big priority for us, and we've now been able to achieve a sustained wait list reduction. We are now able to see most of our children, majority of these children, within 3 months, which is great. So the priority 1 children given allocated a priority 1 are typically seen within a month, and children with a priority 2 are seen within 3 months. And what we've found is that as we've promoted this work, our referrals to some extent have increased. So that's really made me have to think hard about how can we continue to tweak the model to promote timely access to care for these children. So how did we do this? We basically we looked at 2 new models, established 2 new eczema models of care. One was the nurse practitioner-led eczema service, and it was really important when I was starting this work and setting up a new NP clinic was to think about what is already being done by a wonderful dermatology team. What are they already doing really well? So it was really about complementing rather than replacing what was already being done. And so clearly a whole group of very vulnerable children were sitting on our wait list, so they were the group that I was asked to look at. So I had to pull all these children off, I pulled all these children off the wait list and saw them. And so within sort of 6 to 12 months, we had addressed that waitlist issue. And it's really lovely to know that we've been able to sustain that. And we've also established a multidisciplinary eczema allergy clinic, so dermatology allergy clinic. So just a brief overview of the nurse practitioner role. I won't talk about establishing the role just in the interest of time. But if anybody ever needs any help with setting up a new service or writing briefing notes or business cases, setting up a new nurse practitioner service or education clinic, I'm really, really happy to help you. So my contact details are at the end of this presentation. You are very welcome to call or contact me anytime. So the eczema nurse practitioner model at the moment at the hospital is a see and treat model for children with a lower risk, lower complexity eczema, so we still see children with mild, moderate, severe eczema, but so that the complex eczema can be seen by our dermatology specialists. In the nurse practitioner clinic, I see children from birth to 16. And so what typically happens is in terms of being able to address these, the wait time issues and the large number of referrals, one of the dermatologists will triage the new referrals. Most of them will come through to my telephone clinic. I'll take a history. If it's fairly straightforward, I look at the pictures and I think, yep, that's mild, moderate, severe eczema, then I'll prescribe an appropriate topical steroid, write a treatment plan, email a list of helpful eczema resources to the families, and then arrange follow-up within kind of 2 to 6 weeks, depending on severity and what the family, where the family live, etc. We do lots of telehealth for rural and remote families, and also I really like to help support their health professionals in rural and remote areas too, because we can keep most of these children at home in their local area rather than having to miss school, miss work, etc. to come down and see us in clinic. So we currently run 3 clinics, one Monday, Wednesday and Friday in the nurse practitioner-led eczema clinic. We have seen over 1,000 new referrals in the last 4 years since the project's been up, since we've established this position. Now, another aspect of the role is that multidisciplinary eczema allergy clinic that I talked about, and this is really helpful for those children who have got eczema with food allergy or food allergy concerns, because a lot of these families think that because my child's got eczema, that must mean they've got a food allergy, and a lot of them are really worried about introducing some of the common food allergens. And we know that actually the key aims are to optimise eczema early to help prevent or reduce the risk of development of food allergies, and so we want to optimise the skin and promote early introduction of these common food allergens. So that clinic is really, really helpful. We do use a lot of interpreters in our clinics as well, and how we've been able to, so 5 years ago we didn't have the dermatology nurse practitioner role, and that was funded for 3 years, and then over the last 2 years we've been able to demonstrate to the hospital, to our business managers, that we've been able to sustain the position because it's now self-funded. It's a self-funded position through notional activity-based funding. And the nurse practitioner also supports a lot of QI and research in the department. So most of these children do beautifully with the right treatment and the right advice and the right support. They really do very well. So we were really interested in knowing how can we measure the effectiveness of what we were doing. So we asked our families at the start, and we've actually asked our families during the process, during the last 5 years, and recently I've had a look at this data as well. And pleasingly that 90% of families agreed that the service is helpful, and over 80% of families strongly agreed they were better able to manage their child's eczema. So I'm really looking forward to being able to keep up this work and see if I can achieve over 90% of families strongly agreeing. Now, so as part of this, reviewing the effectiveness of the service, I wanted to ask families what did they find helpful about the service, because I think a lot of this is very transferable to a lot of the nurse-led clinics that we're doing, and in fact even some of the medical clinics too. So what families loved was they love a written treatment plan. When I waffle on in clinic a lot, often these families are sleep deprived, they've spent an hour trying to get to clinic, they're tired, they've got, trying to think about the work they've just missed today to get to the appointment or whatever else is going on. So having a clear written treatment plan, they really, really value. They also love the fact that we provide practical demonstration for how to apply moisturiser and how to apply topical steroid and how to do wet dressings, because in almost all cases, when I show a family how to apply the appropriate amount of topical steroid, they say, oh my goodness, there's no way I'm using that much. So they go away, they use the right amount, and next week the eczema's clear. So that it is really worth taking those extra steps. And the other thing that the families loved was the timely follow-up. They love it when you see them today, you give them a call in 1 to 2 weeks, and they can either be discharged or bring them back to clinic in a month. Just that close follow-up, they do very, very well, just to make sure that they've understood what we think they're doing, rather than, oh yes, I'm using the strong one on my face and the black and white tube on my face and the blue, yellow and white tube on my body. Then we say, oh, okay, no, remember the black and white tubes for the body and then the other ones for the face. So really helpful that 1 to 2 weeks, that 1 to 2 week follow-up, just to make sure that they're getting the results that they should be getting, and that things are heading in the right direction. I asked about, is there anything else we can do to improve the service? I was leaving myself wide open here, knowing that it was just me in clinic, but I thought that was really important because I love knowing what I can do better for these families. And in actual fact, this feedback is helping has informed this service, which is why now I have taken this feedback on and continue this in the clinics to date. So our families wanted us to reduce waiting times, tell more people about the service, which I'm not sure if that's great because the referrals will increase, to be more available, this service to be more available for families and to better support GPs and school nurses. So when we first started this work, it was really important to think about the patient journey and who we need to involve along the way. As part of evaluating the effectiveness of the service, we also looked at some objective measures and some patient-reported outcome measures. So we used the POEM score. We used ScoreAD, but we've since changed over to the Easy score because of the PBS listing, and more of us are using Easy scores. So we thought it would be really helpful if we are ever doing benchmarking with other paediatric eczema or paediatric dermatology services, that would be, comparing apples to apples. So you can see the children in green are these children who have had significant improvement. These few children in the blue circles, there was no change, and those 3 in the red had infected eczema and had started their treatment. They were very worried about topical steroids and had actually seen a private dermatologist beforehand, so we had to bring them back into clinic and address their concerns, and then they did very well. So we asked GPs, we had a GP liaison working with us, and we asked the GPs, well, how can we support you to in relation to eczema, managing eczema in children. And so we did our very best during COVID to provide education, at some of these meetings. We did really hope to try and get to their GP conference, but it was in the middle of COVID and we couldn't. And they also asked they do currently have health pathways, but they're very long. So they did ask us if we could put together a 1 or 2 page guideline on how to manage eczema effectively. So we did that, and I'll show you that shortly. So that's one of the ways that we looked at improving referral processes and the quality of referrals. And education and resource development over the last few years has been a really big thing. We included children from all ethnicities and different ethnic groups, and we also included provided education and support for, we wanted to learn more about the community nurses, the child health nurses, practice nurses, and our hospital nurses as well. And pharmacy was also included in this, and I'll talk about the pharmacy model as well. So we ran focus groups, surveys, community conversations. We updated our pictorial information at Perth Children's Hospital and developed a new eczema resource for Aboriginal families. So this is the guideline. When people follow this guideline, the children do so well. We just need to kind of help support our clinicians to keep following this guideline. Now, some of the resource development included here, so we developed some videos and infographics in consultation and collaboration with key partners like National Allergy Council and Allergy and Anaphylaxis Australia. And both Darren Thompson, Emma King and myself were also involved in developing a paediatric atopic dermatitis e-training for health professionals, which is live and on the ASCIA website for anybody who's interested in doing that. But I would encourage anyone who sees children with eczema, and including GPs, to have a look at that website and that online resource. We've done lots of seminars, webinars for GPs. We've written articles for them. We asked them at the start of this work, we mapped out the patient journey, and throughout these last few years with these additional resources, we've worked with the GPs to help sort of identify key aspects along the way that that the practice nurses would be able to have so much positive intervention. So that pathway we talked about, that was the guideline we developed. The action plan we talked about that parents really liked, the written plan, and also the value of the practice nurse. We've developed a flip chart for them and those videos that they can watch. So the structure is there. We just need to, we've still got a lot of work to do in terms of implementing the support for GPs and practice nurses. Now, these are just some of the resources that I was talking about. So you can find these on nip allergies in the bub, and I find these really helpful, especially for doing telehealth. If you've got families living in far and they're not able to come to a clinic appointment to watch you do a wet dressing, then I'll often send them the link to these videos, and so they can see how to correctly apply topical steroid moisturiser, wet dressings, and bleach baths, depending on what's relevant for their treatment. And there are also some infographics as well that they can follow. As part of the education and training resources, we worked with Allergy and Anaphylaxis Australia and developed some webinars for their consumers. They're a partner organisation. And also engaged the pharmacists, because when we mapped the patient journey, a lot of these families will go to the pharmacist first. So it was really important to engage them as well as community nurses and hospital nurses and doctors, including paediatricians, etc. So just a brief overview of the eczema model of care for pharmacists is we wanted to define the role of Western Australian pharmacists as part of their, part of the patient's eczema management team. So we define the tools and resources they require to provide the right care at the right time in the community, because we know that most of these children can be managed in the community. So the three overarching themes that were identified when these focus groups took place. So we did some focus groups in the community, in the rural and remote, in the metro area in Perth, and also in rural and remote with pharmacists and also consumers. And the three overarching themes identified in these focus groups were access to care, consistency of care, and collaboration. So that just helped underpin the work that we were doing, and it was really reassuring to know that we were on the right track. And this is just an example of how this fits into that shared care model. Some of the observational trends that we've seen over the last 5 years, when we first started this work, in my clinic I had, I would say, at least 50% of infants with eczema coming to clinic, but actually now I'm seeing fewer infants. So that's good. I think that's really reassuring to show that these children are being managed well. A lot of them are being managed well in the community. We are seeing lots of increased disease complexity though. A lot of these children with eczema, they've got tricky eczema, they've got multiple food allergies, plus or minus some hay fever, maybe some asthma, so that they're getting trickier to manage. And we're definitely seeing a lot of younger children requiring systemic therapy. We're seeing lots more patients with skin of colour, and this would be a typical clinic day for me. So that's challenging in that, we're using lots more interpreters. We're using the eczema, because of the darker skin, it's not always as easy to recognise and treat. So often these children are undertreated, so they do typically come in with more moderate to severe eczema and more chronic. They've certainly got more chronic and lichenified areas of eczema. So what are we doing about this? There are some things that we're working on. We've recently been working with National Allergy Council on developing some translated eczema videos and infographic translations. There are lots available, so I use these often, especially really helpful for grandparents. If parents come to the clinic appointment and the grandparents at home, then they can go home and show these eczema videos to the grandparents, because often they're the carers for these children. We're currently undertaking a scoping review looking at the atopic dermatitis guidelines globally and how inclusive they are of these different, of these different skin types. And if they are inclusive, fantastic. We just need people to follow the guidelines more. Excuse me, but if they're not inclusive, then we've got some work to do in that space. And we're also working with some dermatologists nationally to develop a toolkit for clinicians to help better be able to recognise and treat eczema and skin of colour. Excuse me. Some of the things that we've learned along the way is involving consumers has been so helpful, because, as I said, that has just helped shape and inform our models of care. Early engagement with our key stakeholders and partner organisations has been really helpful, so particularly National Allergy Council and Allergy and Anaphylaxis Australia, because when you do all this work, you actually want to share it with colleagues so that colleagues in other states don't just have to go and reinvent the wheel. We did engage early with our hospital business manager, and that was very helpful because she was able to help us basically transition from the project-funded position to a now sustained permanent position, so that my position now is, or the dermatology NP position, is now 0.8 permanent funding. So that was a really great result. And I think we did have a GP liaison for the first 12 months, but I would have loved a GP liaison throughout the project, and we've now re-engaged with our GPs to just try and help implement some of this work. And then finally, having a project officer would have been so great, because the clinicians end up sort of undertaking this role, and that then takes away from some of the clinical work that we could be doing. So just to finish up, some of the next steps, so where to from here. The project has finished, but we haven't, because I think we can still do better. So every Monday morning, or most Monday mornings, I have 3 medical students sit in our eczema clinic at the hospital, and they are lovely. They're so keen. They've always got lots of ideas. So we've been asking them because they can see some of the common themes with this suboptimal treated eczema. We still do get lots of referrals relating to suboptimal eczema treatment. So they've suggested that we include some dedicated eczema education into their program. So we're currently liaising with some of the medical courses and facilitators at the universities to see how we can make that happen. We've been asked to continue to share that eczema algorithm with RACGP, so just reminds GPs that that's there to help support them. And also we're really interested in collaborating more with National Allergy Council at the moment to conduct some more focused groups, with GPs and consumers separately to find out what are the barriers for GPs and how can we better support them. Because we do a lot of education for GPs. We go out to their practices when they ask us to. If a child's got wet dressings that they need to do, we'll go out to help the GP and practice nurses. So there's little bits happening, but we need it to be more on a larger scale. So GPs and practice nurses, I think this is the hugest one of the hugest areas of opportunity. Yes. Yes, we do lots of them throughout the year as well. And it's really lovely to see. So when we first started, that was, for those of you who didn't hear that, was the community and child health nurses. And at the start of this, we were getting a lot of families who were saying to us, we've been advised by our child health nurse because our baby's got eczema, to exclude wheat and dairy, etc. So very early on, in actual fact, they were probably our first group that we looked at, and they've just done great. They've done so well. So we regularly, throughout the year, provide updates for them, often at their team meetings. They'll invite, so I've got a couple that I've got to do in the next few months, where we've been invited to go and provide Q&A sessions and updates on eczema and food allergy. So yeah, they've been absolutely brilliant brilliant in the uptake of this information. And now actually I rarely hear from parents that, that children are advised to exclude these foods that have been advised from the child health nurses, so that's great. So I think the focus groups with GPs to help us better understand what some of their barriers are would be really helpful. We do get lots of eczema referrals from our immunology department for eczema support to better optimise their eczema in preparation for their upcoming oral food challenge. So thinking about how can we better support them as well. Often when they're in clinic, we are, the families in clinic with the immunology doctors, they will call us to go down and provide some education, and that's really helpful. It just saves them sitting on our wait list for 3 months. So that's great. And then I think there is a role for an opportunity for improved care coordination with all this complex disease that we're seeing. So they're just some of the next steps that I think that we've identified that we'll be working on in the next 12 months. Yes? So am I the only nurse there? No. So we've got, we had a dermatology clinical nurse specialist 0.6 FTE and me. Yeah. But we're currently working on a briefing note because we do have a couple of graduate nurses who come, and then they're fantastic. We'd love to keep them, but there's no positions. So to make sure that we've got nurses working to their full scope, we really do need support from a registered nurse and or clinical nurse. So yes, we're working on that. Yeah. But I think the important thing here has been just, find your gap, find the area that's a concern, do it really well, show that the service you're providing is effective, and then it lets you gain more traction. I've found that quite helpful. Does anybody else have any questions? Yes. Oh, sorry, Karen. Not as high as people would think, but a higher rate of skin infections. Yeah. Yep, in the First Nations people we do tend to see eczema complicated by infected scabies, those kinds of things, yeah.
How much of the information in your talk is on the web for them?
Just about, so all eczema information about the videos, top tips for managing eczema, that is all on the National Allergy Council. So if you Google NIP allergies in the BUB website, you'll get see all those resources there. And same with the 250K website for teens living with allergic disease. There's lots of information there on optimising eczema management in this group, food allergy, allergic rhinitis, etc.
The GP plan.
And the GP plan, yep. So if you wanted to have a look at that, that's on the GP Health Pathways. And also if you were to Google PCH ED eczema guideline, that guideline will come up as well. But I'm very happy to share any of these guidelines with you because the more people are using them, the better these children are going to do. Karen, did you have a question? Oh, that was your question? Oh, great. Okay.
Thank you. We want to give Gemma a hand, but the other thing that I'll just add is that this project, Gemma's, there's a book that's just been published by edited by Cecily Betts, who's the journal editor for Paediatric Journal, and of paediatrics, and Gemma's the Australian representation. Cecily collated the best models of several countries, and anyone that's got access to university library or the doctors usually would have it, you can actually get Gemma's chapter, download that for your own personal use, or you is it in ebook?
Don't know.
I've got a feeling that you might be able to even get an ebook if that really you wanted to look at other models of care in other conditions, etc. But I think Gemma needs a big pat on the back for being selected as that, because it's just the most fabulous read. And I've read a lot of stuff in the last 10 years. And it's just fabulous. It's not my bias for Gemma either. So
thanks, Darren. Okay. And it was really just to, so I was asked to be the lead author for that book chapter, but I wanted to include, really acknowledge the work of the team. So that's why we included them as co-authors too, because they have contributed significantly to this project. And as I said at the start, it just isn't totally not possible, a project like this, to just have one, a nurse involved. So big team effort. Yeah.
But you
Thanks.
need the nurse to drive it. That's why ADNA exists. So thank you, Gemma. So I'd like to introduce Tanya now, who's going to be talking about xeroderma pigmentosum. Her bio's in the book, so we're not going to regurgitate what's in the book. So welcome. Yeah. Right, which pointer do I use?
Okay. So, welcome everybody. My name is Tanya Henshaw. I'm the clinical nurse specialist at Guy's and St Thomas's Hospital in the Rare Disease Centre as part of St John's Dermatology Institute. So it's a bit of a mouthful, that, so I've got lots of different hats. And I specifically look after adults with xeroderma pigmentosum. So this is kind of where we are. That's the bridge there, Westminster Bridge. So you can see Westminster Parliament there, directly opposite St Thomas's Hospital, so I can see what the government's doing to our NHS right from where we are. So we're right central in London, so it's a big tertiary hospital, we've got a very diverse patient caseload, but we are the national service for XP, so we have patients from all over the UK, including Scotland and Wales. And we've had our first patient from Northern Ireland as well last month. So I'm going to be a bit of a pooper, I'm afraid, but I've got there are lots of gory photographs in here, I warn you now, and I've got a lot of patient photographs from my particular patient cohort, and they've given me permission for teaching purposes only, and it would be devastating if any of this ended up on the web or in somebody else's talk. So if I can ask you no photographs during this talk, I'm happy to give the talk without photographs to Karen later on, and you can all download that if you're interested. So, xeroderma pigmentosum, directly translated, is dry pigmented skin. It was first documented in 1874, so it's been around a while. And this contemporaneous kind of painting is a really good description, actually, of what xeroderma can look like. It's a very rare genetic condition. It's not an allergy to sunlight, which is quite often described as, especially from patients. It's difficult for patients to understand that actually it's a DNA repair issue. So as you know, UVA or UV is kind of bombarding us all the time, and our body is repairing damage from that ultraviolet radiation all the time. And our patients are just unable to repair that pathway either from the very beginning, or there's a problem halfway down the pathway, so they can't complete the complete repair. And the resulting issues are the obvious skin cancer. And there are 8 different types of xeroderma pigmentosum, so XPA, XPB, C, D, E, F, and G, and then a slightly different one called XPV, known as XP variant. So we're learning that these are kind of 8 subtly different diseases, if you like, under the umbrella of xeroderma pigmentosum. They've all got very common things, themes going through, but they've also got slightly different subtle symptoms. So it's described in all continents, all racial groups, male, female equally. In the UK, we've got about 113 patients with XP that come to clinic. We are aware of others out in the community that don't want to come to clinic, but obviously that's patient choice. And it's a recessive genetic condition, and it's a dermatological and neurologically involved condition. And it's the neuro part that's quite surprising. It's described usually as a dermatological problem, but there's a large chunk of my patients that have severe neurological degeneration, and I'll go into that in a bit. And that was a steep learning curve for me as a derm nurse coming into this service. So it's a genetic condition, so it's not acquired, and both parents have to have exactly the same spelling mistake for a child to have XP. So the parents don't have any symptoms, they don't have XP themselves, but they are carriers. exactly the same spelling mistake. So it's really, really bad luck if you get a child with XP. You can have one parent with XPA in their DNA and another parent with XPD, and they won't be able to produce a child with XP. So it's really, really difficult. And it's hard for parents to get their heads around this kind of DNA issue, because they'll have perhaps one child that's completely unaffected, and then they'll have another child that is affected. And they say, well, I've got one child that doesn't have XP, so it can't be genetic, it can't be from me. So there's a lot of guilt from families with genetics, and it's a real issue. But with each pregnancy, they have a 1 in 4 chance of having a child with XP. They've got a 1 in 4 chance of a child having no XP and not being a carrier, and then a 50-50 chance of a child being a carrier. So the obvious symptoms are skin cancer. So that is our main issue, but not all our patients get skin cancer, and I'll explain why in a moment. But our patients have a 10,000 increased risk of getting skin cancer in general, and a 2,000 increased risk of getting a melanoma specifically, and that's before the age of 20. So these patients are extremely high risk of skin cancer. There's also a lot of ocular damage. So wherever UV shines, so up the nose, in the mouth, in the ear, eyes, any exposed skin is vulnerable to UV damage and the consequential cancers. We've got a lot of patients with freckling, and some of them, it's kind of an unusual freckling. It's not the delicate little freckles you get as children across the nose and cheeks. It's quite marked, and I'll show you some photographs in a moment. Pigmental changes, so hyper and hypopigmented changes. Extreme sunburn. We all get sunburn if we're, daft enough to go out in the sun without our sunscreen and hats. And, after 2 or 3 days, it's gone. But with our patients, this extreme sunburn can last for a week, 2 weeks, even months. So it can be very inflammatory, huge blistering, swelling, a lot of pain, and it's very discomfortable. Eye issues are another problem for, especially one of the particular groups, XPCs suffer from eye problems in particular. That's redness, soreness, watery, higher incidence of skin cancer or eye cancers. And then we have the neurological problems, and it's a degenerative condition. So children can be born, have normal pregnancy, normal childbirth, appear normal at very early stages, and then at school they can start to have failure to thrive, struggle with schoolwork, starting to get hearing problems, and then things can decline. So here are some of the examples I was telling you about. So here we've got the extreme sunburn. This young lad, Louis, is now a strapping teenager. But this is with 15 minutes of sun exposure in the shade in the UK springtime. So UV levels aren't pretty high there at that point. And this is what we're talking about, the crusting and the burning. So he had a terrible time, poor chap. And quite often our parents are, when they take their child to A&E or the GP saying there's something not right here, the GP will accuse the parent of abusing the child, leaving them out in the sun for too long. So our parents really struggle with this with them, especially with the young babies. This is the unusual freckling that I can talk. That's not normal for that skin type, is it? And it's quite marked over the whole face, and it's quite kind of darkened patches. And all skin types can get this freckling. So it's type 5 and type 1 is equal. This is an example of the really bad eyes that I was talking about, and I can pretty much guarantee that that child's got XPC. And this is an example of the oral mucosa problems and the severe skin cancer problems. Now, luckily in the UK, we don't get to see these examples in this kind of advanced stage. And the problem is all those patients, the photographs are taken off the internet, and they're all coming from countries that are close to the equator, where education isn't very good, where the healthcare isn't very good. So these patients really, really struggle, and there's pretty much nothing out there for them. Things are starting to change, but it's really, really slow. And unfortunately, Somebody like this probably won't reach the age of 18 before they pass away, unfortunately. And this chap here is an example of our neurology, so you can see the eye differences here. So he's got a slight squint, he's got hearing aids, but look how fabulous his skin is. There's no UV damage there. And that is because patients with neurology tend to be in the group that have severe sunburn reaction. So if you've got a baby that has severe sunburn, you protect that baby with all your might, don't you? So those patients tend to be extremely well photoprotected, and so we don't have any adults with neurology that have skin cancers, and they have fabulous skin. So it just goes to show that photoprotection really works if it's done effectively. So this is an example of the freckling. And this is an Asian example here, and you know, these patients have been told by their GP that this is normal and go away, and it's not a problem. And so these families will go to large weddings and community group meetings, and aunties will be going, what's wrong with your child's face? So the parents are under a lot of pressure to kind of deal with these things. This is another unusual kind of freckling. It's kind of like splotches, if you like. And so the XPE has these kind of strange splotches. And look at that total covering there, that lady. I mean, she doesn't photoprotect. And you can actually see kind of strap lines from kind of strappy T-shirts she wears. This is always patient choice, of course. And then look at this perfect back here. That's an area that's not sun exposed, so again, has no UV damage. So we get the whole gamut of pigmentation problems and freckling. Pigmentation can also be involved in the oral mucosa, in the eyes. I mean, this can be kind of a skin type issue as well, but with these patients it's more common. And we've got these hypopigmented patches. And then we've discovered in our kind of type 3 and 4 skin type patients, it's the hypopigmented patches that seem to be the first symptom, especially on the lower legs and the forearms. And that's what tends to bring them to come to clinic. And you can see how kind of the abrupt stop of the pigmentation changes. So you've got kind of normal skin up the upper arm, and the forearm is quite covered. And we've got the classic on the lips, you know, losing the vermilion border, things like that. But this is this constant, solid pigment changes. It's just not normal for a dermatology nurse to see that, is it? We can, as derm nurses, we can instantly see that that is not normal. And these are examples of this severe sunburning. So this young child, the demarcation line there was actually the different colours in a long sleeve T-shirt. So he burnt through fabric. And this young chap, bless him, he got caught out and he got really bad sunburn on his lips, so you can see how inflamed and painful it is, and that lasted for a good week and a half, that sunburn. In this other chap here, the mother took an example, a photograph of the socks that he was wearing at the time he got that sunburn. And this young chap, James, we could see the demarcation line a year later on his skin. So that nasty burning carried on for quite a while. So the different complementation groups. So we can kind of divide our patients up into two main groups, mostly skin affected and mostly neuro affected, though all patients could have skin cancers if they didn't photoprotect. So they're all equally vulnerable on that front. But we know that these particular groups, these particular groups are more skin heavy, especially XPV and XPC, and XPC are particularly vulnerable for eye problems. We also are learning all the time, and our clinic's been going only for about 13 years now, so we're learning stuff about XP all the time, and we work closely with different teams all over the world. And the US team discovered that a lot of their XPC women were kind of having early ovarian failure. And they said to us, are you discovering that problem? And we went, no, we don't have any problem. And then we realised that all our XPC patients, most of them were either children or the adults were kind of males in kind of early 20s. So we've only just got one adult female XPC, and she does have ovarian failure. So we're discovering things all the time. So for the skin patients, the main issue is constant skin monitoring, and we have some more severe groups and some kind of less severe groups. So the really severe groups, XPV, for example, we would see every 3 to 4 months, and we would be cutting something out of their skin every single 3 or 4 months, and that's even with photoprotection. And it's because XPV has a normal sunburning reaction. So adults with XPV, they've had a normal childhood, their skin has reacted absolutely normally, and it's only within their 20s and 30s they're starting to get skin cancers of all different types. And so the alarm bells start ringing and they get multiple skin cancers. And of course, by then, they've had so much sun damage and UV damage, they cannot repair anything. So in the 30s and 40s, they will just keep producing skin cancers forever. We can reduce the amount that they'll get in the future if we photoprotect, but we can't turn back the damage that's already been done, unfortunately. And with the neuro groups, there are different types again, and there are some less severe and some more severe, and it's really hard to talk to parents about them. Their child, they'll know it's got a neurological problem perhaps, and they just always think the worst. Because a lot of these patients, XPD patients and XPA patients in particular, will be dead by the time they're kind of 25, and they very rarely reach 30. And by the end of their lives, they're in full care, full wheelchair, they need complete care of all activities of daily living. So it's very devastating and desperate for the whole family. But we've got the whole gamut of neuro symptoms. So we've got some patients that have slight hearing problems, slight speech problems, and perhaps a few balance problems in their 50s and 60s, and they've had a life, family, all sorts. So we go from that end of the spectrum to kind of, being in a wheelchair by the time they're 18. So, and we cannot really predict what's going to happen for each individual patient. It's an individual experience with every single one of them, and that's kind of one of the hardest parts of my job, I'd say, actually. And there's no cure for any of the neuro issues. All we can do is support them as best we can, give them as much information. We monitor all our patients, so all our patients will have an MRI, they will all have hearing tests, and they all have peripheral neuropathy tests. So, and we monitor them every 3 or 4 years to track any changes. And that also provides evidence. So when I'm kind of begging the local social services to put support in for these patients, I have to have evidence that there is neuro decline and they do need this kind of support. So having these tests really helps. It also gathers a lot of information for us as a new disease service and kind of learning about the condition. So this is, I've got an example of all our different types of complementation groups. We are the only service in the world, actually, that we're aware of that sees all the complementation groups. We know all the different type of complementation groups. We've got example of all the complementation groups, and we see them all to follow up. So even in the USA, they've just got a big research unit, and patients will come there and they'll get all their samples taken, and they'll get the diagnosis. And they'll get lots of information, and then that'll be it. It's a one-time, one-stop shop, and that's it. They'll be off in the community on their own, and probably just seeing a dermatologist or an ophthalmologist or perhaps a neurologist. So we're exceedingly, exceedingly lucky. So with our different complementation groups, oh, no, I can't get the hang of this thing first in the morning. So XPA, so this is one of the neuro groups. And again, you can see their skin is pretty good on the whole. We do have a strange little subgroup called mild A, where we know genetically there should be a complementation group A, but there's just a slight shift in their DNA, and it seems to protect them from the neurology. Now, we don't know why our patients get neurological problems. It's obvious why they get skin problems, but your UV cannot penetrate the skull. So this is one big area that we're still kind of, a lot of research is going into. So mild A patients, and they seem to come from a particular area in kind of northern India on the Bangladeshi border. So there's a big complementation group there. where at first we were thinking perhaps there's such a mild group, they get freckling, they get pigment changes, but they weren't really getting skin cancer. So we were thinking perhaps we can reduce the amount of photoprotection these patients are doing. And then literally the last 2 years, we've got 3 adults, melanoma, melanoma, melanoma. So as the complementation group is growing older, they're starting to pop things. So we're going, right, okay, back to square one on these patients. So we're learning all the time. This is our XBP patient, and we've only got one. So within a rare group, she's the rarest. She sunburns, and she's just starting to get a few little melanomas. So she's had 2 in the last 3 years. Up until that, she'd had nothing really on her skin. XPC, the eye problems, the main issues, pigmentation problems, skin cancer, and they don't get neuro. XPD, again, we have the whole gamut with XPD. Severe skin cancer because people didn't really photoprotect, even though they sunburnt. And we've got severe neurology. And we've got cases where, you know, he's an adult, he's working in a bank, he doesn't have neurology, but he does have XPD. So we'll see what the future holds for these patients as time goes by. XPE is a big skin cancer group, as you can see, and these patients don't they sunburn normally, so again, they have no idea they've got XP until it's too late to do anything. XPF is another one of those unusual groups where some of them sunburn, some of them get really bad skin cancer, and some get neurology, some don't. So it really depends exactly where the spelling mistake is on the DNA, and unfortunately, that's way over my head, all that complicated genetic stuff. And XPV is all skin, so no neuro and normal sunburning symptoms and terrible skin, unfortunately. But we really do have the whole gamut of symptoms and skin types and issues with these patients. This is a classic XPV back. And this chap, so every spot there is a melanoma in situ, an excision. So we've got a lovely big Aldara patch there, so we know it works perfectly on his back. We're trying to persuade him to work round his back, but he would rely on his wife to do that, and he doesn't want to depend on his wife to do that, but it would work really well, and it clears a lot of the background damage, as you guys know. But we know with this chap, if we biopsied anywhere on him, we pretty much have an MIS. So it's a constant monitoring, seeing which one has developed to a certain stage where we need to cut it out. Luckily, he's very cool about surgery, this chap. Thank goodness. So with skin cancer, now I know I don't have to teach you guys anything about photoprotection. We learn most of our stuff from you guys. The Slip Slop campaign is fantastic. But we have to take it to another level with our patients. So we have to think about their environment, not just their clothing. We have to think of them chemically, so the sunscreens, their lifestyle. A lot of our patients do night shifts, things like that kind of work. And behavioural, so simple little things like just walking on the shady side of the street helps, because the UV damage is accumulative over time. So if you think of a speedometer or the kind of mileometer on a car, with each time you drive it, however short the distance is, you're adding to that mileage. And it's the same with the UV damage for our patients. Quite a lot of our patients think, well, if I just nip out to the car, I don't have to use sunscreen or anything. It's just 2 seconds. It's only nip out. And we have to explain to them it's all those tiny little incremental damages and exposure that add to the overall picture. So it's difficult for our patients to get their heads around this. We, want our patients to live a full and varied life, and they can do that with a lot of planning and preparation, but it is an absolute bore. I mean, they have to cover everything up from top to toe, no exposed skin. And of course, with children, their parents do it, and they're beautifully protected. We get a bit of a problem with teenagers. They start rebelling, and they'll have the visor on as they leave the house, and by the time they get to school, it's off. And then we've got a lot of adults. I've got over 70 adults And only 11 of those 70 adults will actually wear a face visor. I'll show you what that looks like in a minute, and you'll probably understand why. So it's a really big ask for these patients. And none of these things works in isolation. It's the combination of all these things that helps protect the patient completely, the layering up of things. So this is what we mean by extreme photoprotection. It's not sexy, is it? So this is the face visor. And one of the main problems with the face visor, we can't prescribe it. It's one of my biggest bugbears with this job. And we've been trying with research for the last 7 years, so to get a visor that's standardised, properly produced, and so we can prescribe it for patients. Can you imagine, you've got your eczema patient and what they need is steroids and moisturisers? Well, go off and mix your own. It's ridiculous, isn't it? But for our patients, I can only say that, can I say no photographs? Sorry, that's one of our patients. Sorry, no photos. So yes, we have to say to our patients, this is what we advise you to do. Go off and make your own. It's ridiculous, isn't it? So there's a lot of grannies out there that are sewing these hats for their grandchildren. Luckily, we've got a big supportive support group that are producing these visors. But again, I don't know what standard they are. And I know the support group try really hard to make it to a good standard, but it's, I can't guarantee that for all our patients. So we're still striving for that. All our patients get given a UV meter. So if they're not photoprotecting fully, at least they can find the safest place in a restaurant or the cafe or wherever they're going, because there's always a safe place in the school, classroom, whatever. Every bit of skin needs to be covered, including hands. And I can't tell you the amount of patients that turn up to clinic in the summer in flip-flops and 3/4 length trousers. And obviously darker fabrics, things like that, kind of help stop absorption. With the UV, the visor, we know a lot of the adults aren't going to wear that, and I don't push that. We say this is the gold standard, but there are other step-down cases, so, wide-brimmed hat, face buff, glasses, sunscreen, behaviour, environment. Hopefully it all adds up. With the environment, there's UV filter film that we can give to apply to all the windows. It's clear, it's see-through. UVA doesn't come through most glass, so we don't have to worry about that. But UVB doesn't come through glass, but UVA needs to be cut out by the film, and this film cuts out 98% of all UVA. And certain light bulbs emit UV, which is quite a surprise for a lot of our patients. But LEDs are the best. The old-fashioned light bulbs that are no longer allowed, and covered fluorescent light bulbs. Some, obviously using blinds and curtains, patients tend to do, but who wants to sit in the dark all the time, But some patients actually choose to do that. With the neurological management, like I said, this is the hardest part of my job. It affects a lot of different systems around the body. So hearing can be one of the first symptoms, which of course then will affect the speech. Cognition, understanding, so things like memory start to go, complex issues they can't really understand. Balance tends to go, foot placement they find difficult because of peripheral neuropathy. Memory loss I've already described, but and then they get their swallow reflex starts to go, so they get choking problems, inhalation, pneumonia, and they're very vulnerable to lots of infections like bladder infections and chest infections. Kind of the detrusor muscle neuropathy kind of happens, and so they get bladder problems, they get retention, or constantly going to the toilet throughout the night. We're talking, some patients have described 12, 13 times they're going to the toilet throughout the night. And these tend to suffer from kind of diseases of the elderly, like diabetes and nephritis and things like that. So that's another thing we're discovering with our neurology patients. They're kind of ageing faster. And some would actually describe XP as a kind of an ageing disease as well, but research is going into that. But like I say, there's no cure, and we can only support these patients. So we've got 3 clinical nurse specialists that serve this community. We've got me, I look after the adults, and we've got 2 paediatric nurses that do a fabulous job, and they're kind of working part-time. Our roles are very similar, but there's an awful lot of differences. With the children, they have a lot less skin cancer, though we do have children that were 4, 5 and 6 years of age when they started getting cancers on their face. But we've got a handful of children that have skin cancers. The rest are fantastically protected. And my paediatric colleagues will go into schools, they'll educate teachers, they'll make sure UV film is up on all the schools so the children can go anywhere in the school freely, and they tend to get a really good response from that. They do biannual kind of teaching programs for teachers and social workers to come and discover the disease and kind of share ideas about how to protect children in their schools. And they also kind of organise blood cord testing for parents who are having further pregnancies after they've had a child diagnosed with XP. I don't have to do any of those things, thankfully. But with the adults, I get the more advanced skin cancer, I get the more advanced neurology. But I also go into school, into workplaces, I go into universities to advise and try and help find kind of the safest places for my patients to go. And we do home visits all over the UK. And what seems to work best is that we've got a brand new patient, we diagnose them, they do a home visit first before they even come to clinic. So by the time they come to clinic, they've got a good idea of kind of what they want to ask, and they've had a lot of basic things kind of sorted out before they get there. This is the team. It's a large team for a small group of patients. So we're exceedingly lucky, and we're very aware of that. We've got a slightly different funding body. It's from the rare disease funding body. So we've got a dermatological surgeon, we've got 2 dermatologists, we've got an ophthalmologist, a neurologist, a neuropsychologist, particular photographer, we've got dedicated admin, dedicated nurses. So we're really lucky that we've got this team. And this chap here, Professor Alan Lehman, actually discovered XPV, and he's based at Sussex University. So we're very lucky to have a scientist who knows all about the genetics and DNA, and he comes to clinic and he's interested in seeing the connection between the clinical observation and the kind of DNA of our patients. So we're very lucky to have him. So kind of coming to the end now, if you have, we know there are XP patients in Australia, and there's a new fledgling clinic at the Sydney Melanoma Hospital, and I'm going to be visiting them next week, which I'm really excited about. But there's no other kind of services for adults in Australia. So if you come across anybody with that strange pigmentation, strange, unusual sunburning, extreme sunburning, and skin cancers of all types, think XP, think something's not quite right here, so keep that in your mind. And eye inflammation and photophobia as well. We've had patients that have been treated for hay fever for 3 years, and it's turned out to be XPC. So if you want any further information, you can take a photograph of our QR code, and this will take you to our Trust website with all other info on there if you're interested. I think that's it. Yep. Thank you very much.
Thank you. That was fabulous.